Glomerular diseases constitute some of the major problems in nephrology. Glomeruli may be injured by a variety of factors and in the course of several systemic diseases. In the following sections, we discuss the normal glomerulus and mechanisms of glomerular injury, and then the various types of primary glomerulopathies. Structure of the glomerulus. The glomerulus consists of an anastomosing network of capillaries lined by fenestrated endothelium invested by two layers of epithelial cells. The visceral epithelial cells, commonly referred to as podocytes, are incorporated into and become an intrinsic part of the capillary wall, separated from endothelial cells by a basement membrane. The parietal epithelium, situated on the Bowman capsule, lines the urinary space, the cavity in which plasma filtrate first collects. The glomerular capillary wall is the filtering membrane and consists of the following structures: endothelial cells, glomerular basement membrane, visceral epithelial cells, podocytes. The entire glomerular tuft is supported by the mesangium, the tissue that lies between the capillaries and is composed of basement membrane-like mesangial matrix that forms a meshwork in which the mesangial cells are embedded. These cells, of mesenchymal origin, are contractile, phagocytic, and capable of proliferation, of laying down both matrix and collagen, and of secreting several biologically active mediators. Biologically, they are most akin to vascular smooth muscle cells and parasites. They are important in many forms of glomerulonephritis. The normal glomerulus is highly permeable to water and small solutes because of the fenestrated nature of the endothelium, and it is impermeable to proteins of the size of albumin, approximately 3.6 nanometers radius, 70 kilodaltons molecular weight, or larger. The permeability characteristics of the glomerular filtration barrier allow discrimination among various protein molecules, depending on their size. The larger, the less permeable, and charged, the more cationic, the more permeable. This size and charge-dependent barrier function is accounted for by the structure of the capillary wall. The charge-dependent restriction is important in the virtually complete exclusion of albumin from the filtrate, because albumin is an anionic molecule. The visceral epithelial cell is important for the maintenance of glomerular barrier function. Its slit diaphragm presents a size-selective distal diffusion barrier to the filtration of proteins, and this cell type is largely responsible, under normal circumstances, for synthesis of GBM components. Nephrin is a transmembrane protein with a large extracellular portion made up of immunoglobulin, Ig-like domains. Nephrin molecules extend toward each other from neighboring foot processes and dimerize across the slit diaphragm. Within the cytoplasm of the foot processes, nephrin forms molecular connections with podocin, CD2-associated protein, and ultimately the actin cytoskeleton of the visceral epithelial cells. More slit diaphragm proteins continue to be identified, and comprehensive descriptions of their structure and interactions have been published. The importance of the slit diaphragm proteins in maintaining glomerular permeability is demonstrated by the observation that mutations in the genes encoding them give rise to defects in permeability and the nephrotic syndrome. Primary glomerulopathies. Acute proliferative glomerulonephritis postinfectious. Other. Rapidly progressive, crescentic, glomerulonephritis membranous nephropathy. Minimal change disease. Focal segmental glomerulosclerosis membranoproliferative glomerulonephritis. Dense deposit disease. IgA nephropathy. Systemic diseases with glomerular involvement. Systemic lupus erythematosus diabetes mellitus. Amyloidosis. Goodpasture syndrome microscopic polyarthritis. Polyangiitis granulomatosis with polyangiitis hemic Schonlein purpura. Hereditary disorders. Alport syndrome. Thin basement membrane nephropathy Fabry disease. Pathogenesis of glomerular injury and progression of glomerular disease. Antibody-mediated injury is an important mechanism of glomerular damage, mainly via complement and leukocyte-mediated pathways. Antibodies may also be directly cytotoxic to glomerular cells. The most common forms of antibody-mediated glomerulonephritis are caused by the formation of immune complexes, which may involve either endogenous antigens, e.g., PLA2R in membranous nephropathy, or exogenous antigens, e.g., microbial. Immune complexes show a granular pattern of deposition by immunofluorescence. Autoantibodies against components of the GBM are the cause of anti-GBM antibody-mediated disease, often associated with severe injury. The immunofluorescence pattern of antibody deposition is linear. Activation of the alternative complement pathway is an important mechanism of injury in C3 glomerulopathies that include dense deposit disease and C3 glomerulonephritis. Soluble inflammatory mediators, such as cytokines, chemokines, growth factors, eicosanoids, nitric oxide, and activated coagulation factors, also contribute to the glomerular injury. Epithelial cell, podocyte, injury induced by antibodies, toxins, cytokines, infections, and poorly characterized circulating factors is a common manifestation of various forms of glomerular diseases. Progressive glomerular injury can be the result of either primary or secondary glomerular injuries, of diseases that are either renal-limited or systemic, and of diseases that initially involve renal structures other than glomeruli. Progressive injury ensues from a cycle of glomerular and nephron loss, compensatory changes that lead to further glomerular injury and glomerulosclerosis, and eventually ESRD. Progressive glomerular injury is accompanied by chronic injuries to other renal structures, typically manifest as tubulointerstitial fibrosis. Syndrome. Manifestations: nephritic syndrome, hematuria, azotemia, variable proteinuria, oliguria, edema, and hypertension. Rapidly progressive glomerulonephritis, acute nephritis, proteinuria, and acute renal failure. Nephrotic syndrome. Greater than 3.5 grams per day proteinuria, hypoalbuminemia, hyperlipidemia, lipiduria. Chronic kidney disease. Azotemia, right-pointing arrow uremia progressing for months to years. Isolated urinary abnormalities. Glomerular hematuria and/or subnephrotic proteinuria.